Okay, and again, that these things don't normally form, right? They don't normally form, and we talked about a few reasons why. Okay, but when they do form, okay, there's usually something going on here. Now, and it's good that we're going back, because now look at, if you look at your notes, what we were talking about, it really was these three things over and over again, right guys? We just got done looking at this one here. So, if they do form, it's because blood has slowed to the point where now those cells can become, you know, BFFs and they can hang out together and that kind of thing. Or there's damage to the walls of the blood vessel, okay, or to the heart, okay, and then the coagulability factors now increase. So these three areas then are really things to consider as causes if you do have those clots, okay? All right. We looked at some words. We had thrombus versus thrombosis. Okay. The key with this is what? Stationary, right? Okay. And then we have embolus versus embolism. But this one, the key word is what? Movement. It has moved to another location. Okay. Infarct or infarction. That's another good word there. Okay. All right. And keep in mind that an infarct or infarction is not a clot, but it is it can be what? A result of that. Right, guys? Okay. Embolism. Okay. This shows you some pictures. Oh, saddle thrombus. That's a good one to know. Why is that one unique? And why would that cause more problems than just a plain thrombus? You were going to tell me something, that's right. Yeah, because this one now is like a saddle, and you're going to have problems now along both routes. Thankfully, it's rare. Okay, we can have them in the cardiac or in the heart, right? Venous, more common, and we talked about some reasons why, right guys? Why these are more common. We talked about varicose veins, how that could lead to the development, and we then defined varicose veins as being two veins that were really next to each other. Remember that? Was there extra credit right there? Okay, so do some pictures. Okay, we talked about some patients and conditions where we may want to be more concerned about developing these, like they get a patient who has had surgery, he's not going to move, that kind of stuff. Okay, we talked about what happens when they do break off and move to get embolism. Pulmonary, okay. Okay, what kinds of things we'll see in the patient? Pulmonary embolism, shortness of breath, cyanosis, why maybe the SMERS are cyanotic. Okay, what could happen in a favorable condition? Okay, what could happen in an unfavorable condition? Okay, why location has a lot to do with how devastating the results may be. Again, if the blockage is further up, like in the pulmonary artery, that's going to be what? Pretty severe. If it's deeper into the lung, it's going to have some problems, but it won't be as severe. We talked about why. Okay, so a few other words, more things that we might see: difficulty in breathing, pain, chest pain, all of these things we explained. Cough, bloody sputum. Okay. Oh, septic. Yeah, if we go septic, that's a whole other thing added on top. Okay. How we diagnose. Okay, we looked at a few. Oh, and then remember, we had some good discussions on this last time, how, if they're thinking it's pulmonary embolism, then they have to have, again, a high degree of suspicion there, because, other things have been ruled out, or, the history, or they may be involved with something or another. They really have to really think it's this before they really go down that path. But they're gonna really start wanting to order things like a chest x-ray, lung scan, pulmonary angiogram. And then, so know each of these guys, of course, but then, you know, again, not saying that one is better than the other, but what's the difference? Okay, what's the difference? Let me show you some pictures. And remember, pulmonary angiogram, this is the one that gives you the definitive diagnosis, because you can really look at the arteries. I showed you that. It's just a cool picture. Okay, have it as a big wall size at home. Okay. All right, in the den. Okay. And on this one, you can make out, you know, blockages and obstructions and so forth. Okay, treatment. The whole thing here is to prevent what, guys? Blood clots, right? And if you already have one, then we're trying to prevent any more from forming. So the one that what we might want to go with is a heparin, which is going to try and break down what is already there. So we do that one almost immediately, and then we follow that by Coumadin. And they have all kinds of now generic names and so forth for these things. But we might want to follow that with Coumadin, because Coumadin then is look at what we're doing here based on what we're talking about today. Let's knock down those numbers of coagulation factors, so we don't have the problem. But there's a drawback to that, right? So if the patient does need to clot, it's going to be compromised. They're going to have a heart attack. Okay, and that's just what we just talked about. Okay, in arteries, you can have these things forming, but it's rare, and we talked about why. Okay, and then when they do form, again, generally it's because it's more of an issue with an injury as opposed to stasis. Okay, then I gave you some examples like arteriosclerosis. And then depending on where you have your arterial thrombus, they're called different things. Heart attack, coronary artery, again, necrosis of the leg. Obviously in the leg it would be gangrene, in the brain it would be stroke. Again, the same picture there. We can have them in the heart, but again, remember, it's not really due to stasis, it's due more to an injury, whether to the heart itself or to the valve or valves. Okay, and then the third thing to do is that sometimes it's not caused by those things, it's caused more by those coagulation factors increasing in numbers. And then this is everything that we did today. Okay, guys? Okay, so, okay, so what does that mean?